gentlemen and members of the public who may be tuning in to this morning's meeting. This is the 16th of June. It is the Health and Wellbeing Board meeting for Hertfordshire, and to all panel members and all of those you listening, you are very welcome indeed. I have some formal words to read out because, which is rather bizarre and ironic, because this is an informal meeting. If it was a formal meeting, we would be meeting in person. And collectively, we have decided that across NHS, social care and the voluntary sector, we've all probably got enough to do without trekking to somewhere in the county and with suboptimal social distancing. And of course, we're still in the middle of a pandemic, so we've decided to go informal. I will now read some words. Further to a High Court ruling in 28th April 21, the law requires that formal meetings of statutory committees of local authorities return to being held in person. The Health and Wellbeing Board is a statutory meeting of the County Council. For this meeting only, the board is being held virtually, but on a completely informal basis. For absolute clarity, this means that although there will be an agenda, the items on it will be for information only, and no decisions will be made by board members. Any business requiring decisions will be considered at a formal meeting of the board as required by law. In the spirit of transparency, we are live streaming the meeting and permitting members of the public to attend this meeting in an electronic capacity, and there is a link on the council's website for them to do so. We've also made allowance for public questions to be submitted as per guidelines set out in Annex 13 of the Constitution of the County Council. Members of the council are asked to keep their microphones switched off until called to speak, and to switch their microphones off once they finish speaking. Cameras may be left on throughout the meeting if members wish. If you experience connection or other technical issues, it may help to switch your camera off. Cameras should be switched on if and when speaking in the meeting. To indicate a wish to speak, members should use the raise hand function. Use of the meeting chat function is exclusively for noting items on the agenda. Breaks of at least 15 minutes will be held every couple of hours and will be taken after a speaker in the debate has finished speaking. Other breaks incorporated as appropriate. Thank you. There endeth the lesson from the chairman. I've received apologies from Chris Badger and Prague Moodley. Thank you for sending those in. And I'd like to welcome Maurice. Are you here, Maurice? You are, aren't you? I'd like to welcome Maurice Bright, who is the leader of Hertsmere. He's the deputy leader of the County Council and is also responsible for community safety. That's the fire service and all of the community safety roles. And you're welcome to your first meeting, Maurice. Grateful for your attendance. Can we see you? But only briefly, ideally, I think.
And at the moment, slight bandwidth issues.
There we are. You're there somewhere in the ether, but
I certainly am.
That's fine. Certainly not a problem. Jenny Coles, this is your last meeting of the Health and Wellbeing Board. You have been here since inception. You have been with the County Council an awful long time. You came to us in 2010, I believe. The Health and Wellbeing Board in its informal stage started in 2011. You have been through the journey of the Health and Wellbeing Board and of Children's Services throughout that time. Jenny from the hood, you have been a force to be reckoned with in children's services, but not just in Hertfordshire, but right across the country. And the additional value you bring to the whole of the health and wellbeing agenda, working right across with health colleagues in the NHS, but of course in the vol sector as well, is just commendable. Incredibly big boots for the next person coming in to fill, and you have set standards which are recognised nationally. I personally have been, I was on the journey with you for some 6 years, and there were some tremendous achievements, some of which are still rolling through in other authorities, and long may they do so. Family safeguarding and the approach to prevention generally, which has been carried on through Teresa and since my time. But that has made a huge difference in the number of children we have in care and the approach we have to dealing with and supporting those most vulnerable and those most troubled families. So long may that work continue. And when you have left us, Jenny, and I'm not entirely certain you will leave, it's just a rumor, I think. But if and when you do leave us, your work will continue to make the most difference to those people that need it. So thank you so much. And you'll be speaking later on the agenda on the SEND strategy. I just wonder, is there some clapping and all sorts going on here? In fact, I'm worried about an outbreak of exuberance. Does anybody else at this juncture wish to say anything? And I don't expect all 15 of you to launch in, but does anybody wish to say anything at this juncture? You can come in later, of course. You will need to put your hand up if you do. Right, let's at this moment, just bearing in mind I can't see the chat just as we see, we will I think colleagues may well want to say something later when we come to your item, Jenny. Just on that so other announcements, what have we got here? The send item we'd like to get to as soon as we can, because I understand there are time constraints there, but we will first of all, let's just again, because it's an informal meeting, we won't consider the minutes of the previous meeting, but those will be considered next time. So could we have no public questions. Could I ask Jim to come in for items 3 and 4, which of course is the COVID update and the vaccination update, but specifically where vaccination might be not quite as robust as we would like it to be. So, and Jim has also circulated slides which has given us a heads up about what he might speak about. But Jim, if I can give you the floor, just before you come in, I'm not expecting today's meeting to be a long meeting, just generally. As I genuinely think we are in the hopefully the tail end of COVID in terms of lockdown, but I know that health service and care services have so much to do at the moment. We don't need this meeting any longer than it needs to be. Jim, over to you. Thank you.
Chair, should I just elide items 3 and 4 together in the presentation?
I think that's right. They do flow, don't they? Absolutely.
And if people are happy, then we can take the papers as read. So what I'm going to attempt to do is share my screen and hope that it talks to me, and also open the vaccine dashboard at the same time. So cross your fingers. Right, it's doing something. I could sing while we're waiting, but I suspect that would probably clear the room.
It's definitely thinking about it, Jim.
Grand. Can you see the slideshow? I can no longer see any of you.
Yeah, and if you make it a little larger, Jim, that would be great.
How's that?
That's perfect.
Wonderful. So I'll rattle through this as quickly as I can and give you an update. The latest position is that we will remain largely at the step 3 restrictions on the 17th of May, with some exceptions around weddings and commemorative events after deaths. Some changes to care home visiting, which will take effect from the 21st, which we're already working on. And later this morning, I've got a meeting with HC Parts Care Providers Associations and colleagues to go through those. We expect further updates on the 15th and 17th of June. I won't go through this in detail other than to say this slide in detail other than to say the 4 tests have not been met, and so the reason for the extension is multiple, but one of the most important reasons is to enable every adult to have at least a first dose and to get as many second doses as possible in. And of course Jane may have more up-to-date information than I do, so I stand ready to be corrected. I'll skip the events rules and just share that the England picture is that cases have risen sharply after a fall and are expected to continue to rise, not just from positive diagnoses from tests, but from viral RNA from wastewater. The R0 number for England is now 1.2 to 1.4, which indicates we're back in epidemic phase. 1.1 to 1.4 for east of England. The Delta variant is now dominant across England with 90% of new infections. Hospital admissions are rising, but deaths remain at only 0.1% of cases. So we are in a surge of infections, but we are in a different position than we were in autumn. And that's partly because of the vaccine, but also we have to recognise that one of the reasons we don't want to rise in hospitalisation is because the NHS is still under significant pressure dealing with non-COVID. And if we end up with the NHS responding to massive numbers of COVID infections, then we have massive amounts of non-COVID need that is pressing and cannot be met. So we need to stop infections in order for people who are ill and need treatment for cases other than COVID not to be displaced from healthcare services. So our primary duty as residents is one of solidarity with people who need healthcare right now. It's not about just avoiding huge numbers of COVID cases. It's about treating others. I can't emphasize that strongly enough. We can't alter the virus. It's very good at producing variants which are fit. In fact, it looks like at least 2 variants that were around may have been rendered extinct by the new Delta variant. So it's not showing any signs of producing milder, less pathogenic variants anytime now. We're not going to get to zero COVID anytime soon. We might get to low COVID, but actually even that will require some work first. So we're going to have a staged approach. We can't do anything else. And there is no silver bullet. It's an accumulation of lots of small things that in combination add up to prevention. So what does that look like? Well, I think our first 3 priorities are COVID needs to be a manageable infection. We've done it with HIV, although I realise HIV is different. We've done it with many other things. We can do it with COVID. So firstly, we have to reduce the numbers infected. Secondly, we have to reduce the disease severity through not just vaccination, but actually early treatment and early intervention. So our local NHS work on pulse oximeters, for example, to monitor oxygen has been really good on that. Then we need to increase survival rates continually, and our survival rates have shot up since new therapeutics have come online. And we have to seek to reduce long COVID. And we must remember that for every 100 people infected, we may have up to 15 who develop long symptoms that still have a significant burden on the NHS and on their lives going forward. So COVID is not a disease of zero consequence. It is a disease of significant consequence still, despite the vaccine. Then we have to get to low COVID by suppressing infections and outbreaks as much as possible. Now, the bad thing and the good thing about the Delta variant is that it spreads very fast through intra and inter-household networking. And indeed, we've had one outbreak which we have brought successfully under control, where it was seeded in a couple of households and reached about 15 different organisations. That's the bad thing, but the good thing is it makes it able to trace through those networks. And if you do that properly, you can quell outbreaks, as we've done in 2 places in the county. Key tasks for us. I think there are 5 things for us as a system to do. We have to learn to live with this virus circulating. It will still be here in July. It's not going away. So we have to make our events and organisation COVID safe. The second is people need the confidence to live with that risk. So we're putting huge amounts of effort into supporting businesses, and we've just agreed some further funding for the Hearts Growth Hub to support businesses operate safely as much as possible. Operating safely is much better than repeat shutdowns. We need every organisation to articulate their capabilities and role. We really need people to enable one another to care and connect so we can grieve and be alert to the mental health issues, and give people hope so that they can vision the next 2 years, hopefully. before the Delta variant, we really were doing incredibly well in this virus, and I think we were on track to lift restrictions. Unfortunately, the variant has changed a lot of that, and we're in a different place. We can be certain that effective isolation, 90% of people in Hertfordshire who need to self-isolate are doing so according to our figures, in fact, slightly higher. Effective home testing, increasing the numbers doubly vaccinated, and wearing face coverings indoors, as well as ventilation. We can be certain these will reduce the size and the harm of the episode of infections we seem to be going into. We can also be sure that ignoring symptoms and not isolating, and lack of testing and unmasking in crowded, poorly ventilated spaces will make it a great deal worse, as will refusal of the vaccine. So we do have the ability to control this. This is an England diagram which shows the change in cases on the right in blue. You'll see it's a significant fall, and we've had a significant rise again. And you can see on the left, hospital admissions are going up much more slowly. But it is not just a matter of we've got lots of hospital capacity. We haven't. They are busy. The Hertfordshire picture, you can see there, we've had a doubling in just a few weeks, largely due to the Delta variant. Our hospital admissions are rising much more slowly, or at least they were on Monday, than anywhere else in England, across the east of England, but I expect that's not going to last. We have curbed a major rise in Watford and are employing the same tactics in other areas.
That's great.
But our rates are high, and I'll skip this slide. And you can see, actually, I just want to point out to you that, you know, we've had a couple of areas who've gone up, gone down, and gone up again. If you look at places like Watford, the more or less everywhere is rising now across the county. The government's full tests, vaccine deployment has been met, despite the fact there are inequalities. Fully vaccinated people rate has been met. There are inequalities. The infection rate test will not be met if the doubling rate continues, and the assessment of risks is fundamentally changed by this variant. So that's what we need to bear in mind. You can see here that the numbers of vaccines are rising significantly, but we don't have enough people fully protected yet, so we need to get there to avoid disease. And if you look at the figures, you might think that Hertfordshire is actually much lower than the rest of England. England's at 78%, we're at 56%. Actually, part of this is because our age structure, and these figures are not age standardised. Our eligible population has risen to 1.2 million from 880,000 because our under 45 populations are higher in most other areas than England. If you look at the vaccination uptake by cohort in Hertfordshire, every cohort down to age 50 has over 80% first vaccine uptake and over 70% second vaccine uptake. The first dose is high in even those younger cohorts where we haven't had 12 weeks yet between doses. That's great, actually. That is really good. It is showing that the vaccine hesitancy is not impacting us as much as we feared. But we do still have inequalities, and we do still need to do better. And if you see this map, you can see that there are some bits of Hertfordshire where we do need to significantly increase, and the Health Protection Board, working with the NHS, have set up two programmes. One is a joint NHS public health vaccine uptake cell, so that is doing things like vaccine pop-up clinics, walk-in clinics, hearts and beds Afro GPs running special clinics. The other programme is funding district by district a programme of increasing vaccine uptake. So to take
sorry Jim, what is that map showing us? Apologies cutting across you.
So this map, the purple is the lowest uptake of vaccine per area in Hertfordshire, and the yellow is the highest. So you can see there are some areas of Hertfordshire have got very, very high uptake in yellows and greens, and there's a few areas in purples that have got very low uptake. So it is not an even geographical picture. So there are geographical inequalities, not just inequalities by ethnicity or age. Does that make sense? And forgive me, I can't see anybody because of the slides. So
no, that's great, Jim. Thank you.
It's really helpful if you just interject, as it were.
So, sorry, Jim, if I can just interject. Presumably that slide equally is a non-age standardized slide. I'm just trying to mentally reconcile the figures with what I know about uptake by super output area, and I think, just to sort of clarify for the board, some of what appears to be very low uptake will be a function of very limited older age populations in some of those areas. It's not the complete explanation, but there's two things going on, I think, Jim.
You're absolutely right. So if you look, for example, at some of the bits that are in yellow, those areas have a much higher level of older people in them, one or two of them.
Yeah.
Whereas the areas in purple, some of them actually have quite a young population in them. So and I think this is illustrated slightly better if you look at this heat map, although you may not think so, but I quite like heat maps. You can see ethnicity is on the vertical axis and deprivation is on the horizontal axis. So I haven't shown the one that includes age as well, because that just is mind-boggling. But you can see actually there is an age difference, but there's also an ethnicity and a social deprivation difference. We are able to work right down to lower super output areas to actually target vaccination. So, for example, we've just agreed £200,000 to Watford to do targeted work in areas where the vaccine uptake is lowest. And as Jane says, it is typically that you have to filter out the younger people because the national figures are not age standardised. So you have a bit of interpretation to do, and it would be wrong to say that we are poorly performing on vaccination. Actually, many of our vaccination uptake levels are higher than the national rate, but it's our age structure that masks that sometimes makes it look worse than it is, and it isn't. That doesn't mean we can be complacent, because we have a lot of work to do. I'll skip these slides if I may, other than to say our hospital admissions in Hertfordshire remain low for COVID, but the hospitals are very busy for everything else. And our mechanical ventilation beds remain low for COVID, but the hospitals are busy, so we want to avoid this. If you look at this slide, this is again a national slide, and you can see the change. So the browner it is, the faster the change in infection. The bluer it is, the faster the reduction in infection. Most of the country is now increasing in infection rates. And the danger with that picture is the doubling rate. Because if your doubling rate in infection is between 4 and 11 days, you are going to see infections turn from 100 into thousands in less than a week in a local area. That's the challenge we want to avoid, and that's a risk, and one of the reasons for the pauses. I think I've explained this slide, Chair, so I'll skip. If we go on to vaccine effectiveness, it is actually good news still. Yeah. From if you pour through the latest data, actually 2 doses of the vaccine, whether it's Pfizer or Oxford, are over 90% effective against hospitalisation. 2 doses of either vaccine are over 80% effective against symptomatic disease. We don't yet have these figures for Moderna and Johnson & Johnson because they're not as widely spread. But look at only 1 dose, 30%. This is partly what explains why so many people who are currently getting ill are only partially protected, and why we really, really need to get the vaccine fully into people's arms. So that's 2 doses plus 14 days after, and this 4-week pause will be helpful. New estimates suggest that after 2 doses, there is an 80% protection against infection as well, which is a lot higher than we thought. But those are estimates and they have not been confirmed yet. They're still being investigated. But 80% protection against symptomatic disease from either vaccine. I've had the AstraZeneca. I was expecting 66% protection. The fact that it's 80% is a boost. That's very good for a vaccine, and 90% and over for hospitalisation. We should be really, really pleased with this, even with the Delta variant. There's a lot of noise going around about 12 people who died despite being fully vaccinated. What we need to remember is that actually of 33,000 people who had the Delta variant at the time this study, the PHE study, was done, we knew that 30,000 had been vaccinated. Only 6% of people who were fully vaccinated got infected. That's actually lower than we'd expect from, the figures I've just shown you. And of that 1,785, only 12 people died, so that's 0.7%. That's actually a helpful statistic, but it still shows that the vaccine is not a magic bullet and we have to do other prevention. I'll ignore these slides if I may and just come on to the variant in Hertfordshire, and then I'm sure you'll be pleased to learn I'll finally shut up. 2 slides on the variant. The Delta variant has a particular marker on the spike gene, the S gene, which means we can actually now detect it slightly more quickly when we do a PCR test than still waiting for full genomic sequencing. That means we can respond to presumed outbreaks of Delta variant actually a week more quickly than we could earlier. So if you look at the green there, this is the Delta variant, and the purple is the Alpha, the Kent variant. What you can see is that the green has more or less crowded out the purple, the Kent variant, and is busily crowding out a lot of the yellow variants. So these are all the other variants that are around where we don't have a spike marker at the test, but we can sequence them later. And that's really important because it shows the Delta variant is so fit, it's crowding almost everything else out, although the Kent variant is still competing. This slide is even more dramatic because actually we have had in the past 4 months cases of a range of variants, and you can see those variants listed in grey. What we've got now essentially is mostly Delta with a very few Alpha variants, 1 or 2 of the variants first identified in South Africa and a couple of unknown. The gene pool, the variant pool has shifted dramatically, not just in Hertfordshire, and this is typical of the rest of the country. So I'm going to stop there if I may, and give you all some strong coffee.
That's a really comprehensive introduction there, Jim, right across infection and vaccination. Really, really helpful. I think you could have been stood alongside Boris and would have been equally as coherent. And your slides actually make more sense than the reliance by Boris. So, Paul, if you'd like to come in first, thank you.
Yes, thank you very much, Jim. Very helpful. It was really at that last slide that's prompted this question. That displacement of the other variants, and I guess the original as well, the Alpha, as you say, and this sort of replacement by the Delta variant, does that have any implications for sort of the natural history, the evolution of the virus in terms of does it reduce the risk of new variants or increase the risk of new variants? I've not seen much commentary or modelling of what we expect with living with a virus, what our expectations can be about it mutating further and so on. Just looking to give a comment on that.
That's a very good question. I think it means several things. I think, firstly, so what we think we know about this virus is that like most coronaviruses, it produces variants like there's no tomorrow, and a lot of them are just not very the term is fit, which means that they're not great at transmission and they're not great at spread and infection, and they die out. This thing has produced some really fit variants that have been able to not just be variants, but have also either mutated or have recombined with other variants to create even more transmissible variants. So what we're seeing is what we would expect with the virus is mutations are taking us, or variations are taking us into higher transmissibility in the first few years, not lower transmissibility, but they're not taking us into milder pathogenicity, although they do seem to be changing the symptom profile. There's good news in that, because the more fit a variant, the more it just crowds out everything else. And we've seen, I think, 2, possibly 3 other variants that were around in the UK more or less becoming extinct. That means that other newer variants have it so much harder. But the real risk there is if you get a variant that's even fitter than the Delta variant and even more pathogenic and evades a vaccine, then we're in some difficulty. So I choose to interpret that we have a window of opportunity to get as many people doubly vaccinated as possible while the Delta variant is the dominant variant, before either another variant comes along that's even worse, or if it's a vaccine. Have I answered that? Is that clear?
Yeah, I think that's I think that's the right level of inferred frighteners that you're putting on us, Jim, which is probably helpful to let us know that. Can I bring in Morris and then Steve Palmer?
Yes, thank you. On that last point, so are you saying, I mean, that's not why I put my hand up, but are you saying that the more we get people vaccinated, the more we stop the spread of the variant? Now, we know that there are new variants emerging every 3 weeks or so, but the more we can get done by way of vaccinating as much of the population as we can and building up as much resistance to the current variants, the less chance of something else coming along and striking people in massive ways because they've really got some protection. Is that what you're actually saying?
Absolutely. Every time you spot on, every time a person gets infected, the virus gets a lottery ticket to develop a new mutation. Okay. And if you think that the origin of the Kent, the B117 variant, was probably in somebody who was immunosuppressed, who had been infected by several variants of the virus, and this new variant emerged, you don't want that happening again. So the more people, exactly as you say, Morris, that's why I think we're in a bit of a race.
It's a bit of a vicious circle, isn't it? Because the more people get double vaccinated, the more people feel safe to go out. But as you say, they might be carrying something that might not be safe. But that aside, assuming we haven't got the doomsday situation quite yet, I was chairing a meeting of the local strategic partnership yesterday and spoke with Dr. Kate Page, who's many of you will know from the NHS and the CCG. And she was saying that in the last week, the number of positive tests that they had at their surgery was was 10 times what it had been a few weeks earlier. But she did agree that the link between infection and hospitalizations had been broken because the nature of the people who are now catching it. Yes, there were some people who hadn't been double jabbed yet of a more elderly nature, but by and large, it was younger generation who hadn't had it yet at all and also had a much milder form as a consequence. And I think that's well worth noting. My 24-year-old son, as soon as he could yesterday, last night, he's booked to have his, I'm taking him tomorrow to have his now. I mean, it's really, really quick. So I do see why the 4 weeks is necessary, and away from the noise of social media, I think most people do, especially coinciding with the end of school. So I think we just have to keep doing what we're doing, make sure we get our messaging out there, and hopefully have a safer summer. But there may be a third wave coming, but it's going to be a different type of wave to what we've experienced before, and I think we have to remain positive and focused on that.
Thank you, Mark.
That's an excellent analysis.
There we go. Good. Steve Palmer. and then Sarah Wren. You're on mute, Sir Steve.
Yeah, sorry about that. Yes, thank you. Just a quick question, whether the dominance of the Delta variant makes it more likely or less likely that we're going to need a booster or not?
I think this is a $1 million question, isn't it? I mean, I think there are three factors in whether we need boosters. And I think we're expecting an announcement on phase 3, which will be the flu vaccine and the booster. Jane will know more about this, but the issue will be whether the flu vaccine and a booster can be co-administered, or whether actually that is the wrong thing to do because your body responds to one and not the other. We don't yet know about long-term immunity either from the vaccine or from, real long-term immunity or from infection. We know that natural immunity is not enough to protect you from infection in the long term, regardless of what some of the stuff written out there says. We know that the reason for boosters will be to protect against new variants. So I think it is more likely than less that we will get a booster to protect against new and emergent variants. But I think we're all surprised by some of the really good things some of the really good data that came out on Friday about this, which means that the booster may not be as essential just for this variant, but for others. Okay. That's my reading of the science. It changes by the day, so by Friday I'll probably be wrong.
I think, Jim, from what you're telling us this morning, is that whatever the success of the vaccine program, and it is essential that as many people get vaccinated as possible, and echoing what Morris said, 23-year-old daughter's boyfriend yesterday was invited and took up the opportunity to go and get vaccinated. Fantastic. It's going right down the age group. But you're effectively telling us that we are going to still have to be incredibly careful around our own personal hygiene and just how much interactivity there is. It's you're not kind of telling us to go out there and party just at the moment, are you?
No, I mean, so this virus ain't going anywhere. Despite the message in some of the media that 21st of June is Freedom Day, the virus has declined to accept the invitation to leave our borders because it's a virus and can't read. That fundamentally means it will just keep circulating and just keep circulating. And what we know from the history of public health is that there is no magic bullet. There never has been against any disease. That happens in Hollywood. It doesn't happen in real life. And it's a combination of measures. So you reduce your risk by getting 2 doses of the vaccine. You reduce your risk further by ventilating spaces that you're in with other people you don't know. You reduce your risk further by wearing a face covering. And you just reduce your risk further by hand hygiene, particularly if you're in a place where there's a lot of aerosol or droplets on surfaces. It's less of an issue in other areas. So we just need to keep on going with these. And we have demonstrated we were doing really well. I mean, really, really well before this variant came along. And we can do that again because actually we've proven we can reduce infections. Look at our track record.
Okay, Jim, that's great. Thank you. Sarah, and then I'll bring in Jane.
Thank you very much. Yes, thank you for the update, Jim, which as always is really comprehensive. We've come across particular vaccine hesitancy amongst individuals who have previously had the virus and are therefore saying that they don't need to be vaccinated, but also some cases of individuals who are getting information from what I would refer to as quite a dark source and are still part of this sort of belief that, this is all a big conspiracy and whatever. I was just wondering about how that sort of quite insidious dark media is being tackled, and if there is a way that we can reach out, because it feels to me that the more we try and say to these individuals that this is nonsense, the more they believe that we are part of this big movement trying to sort of, you know, convince them of something that is untrue.
So the good news is that all of the trackers that have been done show that 96% of the UK population will get their vaccine. So, and that intention to vaccinate. So the anti-vaxxers are not getting anything like the purchase that they are. But my postbag on a daily basis still has emails saying, prove to me this virus exists, because it doesn't exist. And there is a lot of what I call schmimmunology of people coming up with basically nonsense about, you know, immunology and so on. There are three things we can do. The first thing is we can combat misinformation by reporting it and having it taken offline and having it checked as accurate. And point out to people pushing misinformation that if somebody acts on it and becomes ill, then they potentially have a liability for that person's injury. I think the second thing is we need to build vaccine confidence. So every single person on this call needs to be confident about the science of the vaccine, the basics, needs to be confident that the vaccine works, and needs to spread that confidence, and that psychologically will help. Now, I declare an interest because I'm a member, but the British Society for Immunology has a fabulous public-facing website. It's really brilliant. And Adam Finn from the BSI is a great friend to Hertfordshire because he's spent several hours on BBC Three Counties Radio answering residents' questions. And it's people like that, plus our nurses. So we start with confidence. And the third thing is treat every single question as an honest conversation and answer it honestly and factually. And that's the most important way of combating misinformation. So the Heart Care Providers Association Vaccine Hub is something that, you know, we've done a lot. I know you and a whole load of others and I have put hours into that, but that I think is our best strategy. And talking to people, does that help?
Thanks, Jim. That's really helpful. Jane.
Yeah, there were sort of a few things that Jim referenced through the earlier presentation that I thought it might be helpful if I just provided some sort of additional information and perspectives on, Richard, if that's okay with you.
Yeah, please do.
I think the first thing probably is the current state of the vaccination programme and the rollout. As we've recognised, it's reaching down now into the youngest adult cohorts, and what we're seeing is pretty much as much appetite for vaccination in those groups as in any other group. Having said that, because of the nature of people's day-to-day lives and the relative relaxation of restrictions compared to when we started the programme in December and January, what we do recognise is the need to make as much vaccination capacity available effectively in the early evenings and at the weekends, because many people are working and given the economic fragility, are understandably a bit reluctant to ask for time off. So there's a balance there, but I think it's important for the board to recognise that there's nothing that we're seeing which suggests any real vaccine hesitancy that is different in these age groups, and indeed quite high reported sort of levels of altruism, in the sense of I want to be vaccinated because it protects, you know, older members of the family or older members of society. I understand that my own personal risk benefit sort of calculation is possibly not as big a motivating factor. So I think that's really positive. I think on the slightly just to be aware of side, I think some of the thinking around national communications to support rollout of vaccination at the moment may well give a slightly different message to the one that Jim has correctly articulated. So I think there may well be a bit of a sort of a blunt message that says it's important to get the vaccine so we can unlock properly. and then you won't have to bother about any of these other measures. So I think we're going to have to, and I suspect there is nothing we can do about that. And at one level, it's understandable, but I think it will be all the more important that there are local messages that don't undermine that, but place it in the correct context, as Jim has outlined, in terms of, yeah, it's great, but this is relative progress. This is not a silver bullet. And what we really need is to suppress levels of circulating virus, so we don't see further variants in the way that we have been seeing. The third thing I wanted to touch on very briefly, and there is very limited formal intelligence on this at the moment, but clearly there is a lot of thought and work going on to what's being referred to as phase 3, or we would recognise as boosters in the autumn. It is almost certain that there will be a booster programme. There are, I think, now potentially 5 different vaccines that may or may not be part of that programme. It's not clear whether there will be a recommendation to have a booster of the same type you've already had, or a different type to the one you already have, or whether it makes no difference at all. Clearly, for logistics, the third option would be preferable in terms of delivering the programme. It's also not clear at the moment whether there will be the scientific advice soon about whether flu and COVID boosters could be given at the same time. But even if the scientific advice is that this is a safe thing to do, and it probably will conclude that, but I stress probably, again, the logistics may well defeat us, because flu vaccination is rolled out predominantly through individual general practices who will have already booked and paid for their vaccine supplies over a year ago. So that's already hardwired in. And the national ongoing rollout of COVID will continue to be through primary care networks, not individual practices, alongside vaccination centres, community pharmacies and others. So it may well become possible to have your 2 vaccines simultaneously in a purist sense, but it may not be practically deliverable. So again, we just need to sort of start the thinking about some of those aspects in terms of how we manage our local comms and support, because the autumn, she says, in not yet quite midsummer, will soon be upon us. So we're planning ahead. Those were the 3 key points I wanted to raise, Richard.
Oh, you're on mute, Richard.
Jane, some serious challenges there. It's really helpful to alert us to those, because of the need to get on top of the waiting list that the NHS is already battling through. We need those booster flu type jabs to enable that to continue as uninterrupted as possible into the autumn winter, for as long as possible. So that is a really serious point, the third point that you just raised there about the logistics around a booster vaccine. And I suspect we all would encourage you to take that away as something that you could perhaps update us when we next meet, Jane. That would be really helpful. Thank you. I think Maurice, probably briefly, and the last speaker, if you'd like to come in, Maurice.
Yes, please. I mean, what Jane has said to me just now, I've heard as well, and it troubles me slightly, the third point about the boosters and flu vaccination, that indeed it will need to be two jabs. But I think that logistically, if we don't find a way of being able to give people 2 jabs at the same time, the difficulty you're going to have is people will start in their minds doing calculations saying, well, look, the flu jab's only 60%, 65% efficacy and works, whereas these boosters might be 95%. I'll just go and have the COVID one. And we could have a flu issue. And that troubles me. If you can get them done in a mass centre at the same time, whack, whack, in they go, I think it's going to be much easier. I hear what you're saying about purchase and local centres, but I really do believe that could be a problem to come back and haunt us. And the other issue is around, I think we have to be a little bit careful with comms. I like seeing the queues of people, as we did on the news last night, of young people particularly queuing up to have it. It's now become quite a cool thing to do, rather than rebel against it. But if the messaging is, well, you know, you're going to have to, you can have it, but you still shouldn't be going out and trying not to, you've got to be careful not to spread it, because it may not actually work if you give it to someone else, etc. They're going to think, well, why are we bothering? You know what young people are like. So I think we have to find a way of keeping the messaging as positive as possible, because as I say, if anyone's going to fall off the radar, it'll be them saying we can't be bothered because we're told we're not going to get it that bad anyway, and then that whole spreading back to older people starts again. So messaging's got to be careful, and as I say, boosters and vaccinations, if at all possible, with flu rather, in the autumn, need to be as conjoined as possible by way of process to ensure that people don't decide only to have one, not the other.
Thanks, Maurice. I think I have been reassured today, and I've been keeping an eye on the social care figures, particularly those in care homes and domiciliary care, for example, that things are still under control, and infection isn't at the moment an issue there. I'm reassured by the age cohorts as we get into the younger. There is not a reticence and not a hesitation to uptake, and I'm really pleased by that. But obviously, just reflecting on what Maurice has just said, we may need different methods and ways of communicating, and I'm sure that's in hand. But is there any, Jim, just as a final comment, do you have any final word?
This is a marathon, not a sprint.
Okay.
Or a bit of a long hurdle race, and we have to get over the hurdle for the next 2 months of the Delta variant in 3 months. Then we have to get over the hurdle of the boosters, as Jane and Maurice have been discussing. And at the same time, we need to do everything we can to protect every vulnerable situation that we know is vulnerable, so social care, schools, and many others. So we basically need to keep, steeplechase is probably more accurate, I think, Jane. So we have our work cut out for us. But if our residents are with us, as they have been this far, they are, if there is a magic bullet, it's our residents, because they have been so far.
Yeah, that's a really good point to finish on, Jim. Really good. These are important few weeks coming up, and our message has got to be: get your jabs in now, and you're going to make a difference for our population right across Hertfordshire. And as you say, Jim, it's our residents and taking them with us that has made the difference so far, and long may that continue. And so I think that's really appreciated, that update, and I think it sets the tone for when we meet in I think it's September, that we are understanding of how we are going to and able to give with some confidence how we're going to offer up flu and or vaccine boosters and how that will happen. I know more will come out before then, but that would be really useful, I think, to have as an update then, again, to be able to reassure our residents. Thank you very much. And thank you for all the contributions from everybody. That's really helpful. I'd like to move us on now to agenda item 5. And Jenny, I wonder if you'd like to introduce Danielle Bailey. I see, and or Joe, but Jenny, would you just like to introduce the draft SEND strategy, and then to introduce those who are presenting this morning? Thank you.
Yeah, absolutely. Thank you. It's a pleasure to bring this here now. We know, as you can see, this special educational needs and disability refresh of the strategy. Firstly, we've decided that because of particularly over the last year and the impact of the pandemic, but also the changing scene around special educational needs and disability, that this refresh should be done early. And then the second thing is that we are keen to have brought it here in its draft form. And as you can see from the report, there's going to be a series of engagements events in the autumn term, and a whole variety of communities, families, professionals and children and young people. So I'm going to leave it to Danny Bailey and Joe Fisher to give you the details. Thanks, Richard.
Thanks, Jenny.
Thank you, Jenny. Richard, if I may just give a few words of introduction before I hand over to Danny for the detail. As Jenny said, the draft strategy in front of you sets out our refresh strategy, and we're really here today to invite feedback and comments on the strategy, including our proposals around stakeholder engagement and the timeline. By way of briefly scene setting, the strategy builds on and really takes to the next level our SEND transformation programme, which we launched back in 2019 with a very clear aim of both improving outcomes for children and young people, but also better managing the increase in demand and the increase in costs that we've seen across the system of all of our support services and across the country, but also in Hertfordshire. We've seen a massive increase in the numbers of children with education healthcare plans in the past 5 years. It's more than doubled. And alongside that, increasing complexity of need, particularly in relation to autism, social communication difficulties, and social and emotional mental health difficulties, with a correlation often with increases in requests for specialist provision and special school provision, meaning that children are often placed outside of the county, far from their homes and their families. Now, in the past 2 years, we've made significant inroads into really addressing some of the key and most pressing priorities that we've co-produced with a range of partners, including our parent carers. So we've reformed our funding for children in mainstream schools so that we can better meet their needs, as well as increasing the number of special school places by over 250 in the past 2 years, with plans to increase and build on that by a further 300 places in the next 4 years. We have done a huge amount of work to increase the quality of our statutory assessment and review process for children's plans, but also reshaped our advice and information and guidance so that there's a single point of contact and place for families to go to get help. However, there's still lots to do, and we've certainly got our work cut out, and there's some real opportunities, particularly when we think about the opportunities to work and collaborate greatly more with our health colleagues as part of the integrated care system. Our new strategy really sets out our aspirations for this and about getting it right for our children and young people. It both recognises the breadth of activity that we've got to undertake, but it's also clear about our vision, the outcomes, the benefits, and how we're going to get there. If I now hand over to Danny, just to give you some of the detail. Thank you, Danny.
Morning, everyone. I'll just get some slides up because it's obviously quite a weighty document. It's really easy if I run through it via slides. So here we go. Let me know that you can all see those if that's okay. Right, so I won't reiterate obviously things that Jenny and Joe have already covered, but obviously this was meant, the current SEND strategy was meant to run until 2023, but obviously as Joe and Jenny have both explained, there's been so much that's happened, whether it's the pandemic, significant hopeful improvements within the SEND transformation programme, but yeah, huge change in demand that needs a refresh basically. So that's what we've worked with a really great task and finish group to start to pull together this new obviously refresh that we want to share with you and take your feedback today. So a couple of things just to sort of say how we've got to where we've got to, and as just to reiterate again, this is a complete draft. So we've worked with a task and finish group that's had representation across education, health, social care, and also parent reps, school reps, head teachers, to basically get to where we are today. But it is still in draft format before it goes out into the community for their feedback. As well as that, understanding that we've got a brand new children and young people's plan internally and ambitions there, what we've looked to do is ensure there's a golden thread to the ambitions that obviously we're pulling together within that children and young people's plan that flows all the way through into the SEND strategy and our SEND ambitions. So that golden thread is really, really clear all the way through. So we've had this tight task and finish group, but the next bit really is us sharing it more broadly for feedback. This is the brand new SEND strategy vision. If you're wondering where the colours are coming from, so the local offer has a new colour palette that was agreed with parents, carers and families. So we've again looked to replicate those colours as being agreed through that forum. So here's the new SEND strategy. We think, you know, it's very easy to live and breathe. And the tagline that we really want to go with is that SEND is everybody's business, and we want that to run through all of the communications events, the local offer, and everything we now do within SEND strategy and previously SEND transformation. So yes, so we're really keen on this vision. Again, all of the Task and Finish group have signed up, but we now want to start sharing that more broadly. These will all be familiar to you all, I'm sure. So these are the Children and Young People's Plan ambitions. And what we've literally done is used each ambition within that plan and then linked them directly through to the SEND ambitions. And hopefully you've seen that through the document, the draft document that you've seen that we shared previously. And that's really what we'd like your feedback on. Have we really captured all of the areas that we need to capture and the detail? So yes, so hopefully you've seen all of these before. So again, the priority for us in this public-facing document, so behind the SEND strategy will be a significant action plan that we will monitor and manage and report into SEND leadership group and publish our progress. But the SEND strategy that we've shared with you today is what will go out to the public. And the key bit within the strategy is the SEND ambitions. And what we've looked to do is really have our children, families and professionals at the front of this. How are we going to make SEND services different, improved for our children, families and professionals? And what we've tried to do is ensure that each of our ambitions start with a verb, so a doing word. So what are we actually going to do? How will it feel? How will it be different? So it's tangible. So starting again with how it feels, so breaking it down across children, families and professionals against each of our ambitions. So the example here we've got is enabling. This is how it's going to feel different. And this is how we're going to measure. So the actual tangible things we're going to do and then how we'll measure that progress. So those progress measures in the right hand corner will be part of our action plan. And what we will do is report into SEND leadership group and then publish our progress on the local offer, again for transparency. So what we'd like really your advice on and some further ideas. These are the main parts of our engagement plan, but I did share with you the broader and more detailed plan. So this is what we're sort of working on at the moment. So for community events entitled SEND is Everybody's Business across the county, we will be inviting all of our SEND services, so professional services, but also our community groups and partners to those events. We're also looking at working with people like Mudlarks to do the catering, again, to really showcase our young people and what they can do at these events and invite the community in. So you'll see the SEND strategy ambitions weaved through those events, but actually making them useful, informative and sharing support and services at those across the county. And we're just firming up the locations at the moment. As well as that, appreciating how busy our professionals and colleagues are and families, a series of webinars. So there'll be health-focused webinars and education-focused webinars. Sally Orr's supporting us with the health ones for your information. And then the head teachers have been supporting on the education webinars and also some Senko briefings as well. And I think the detail is in the paper that I shared. And as well as that, for our young people, a public drawing competition for primary, secondary and FE. We'll be running that across schools, but also asking the public to vote for their favourite drawings on the local offer. And those images we will use not only in the SEND strategy, but also on the local offer as well, to really make it real. And, you know, we love the designs that we're coming up with so far, but we'd really like to include some of our drawings as well. So this is the current timeline that we're working to, and we're continually adding new events and activities that we need to engage with and be part of. So if you see a group that actually you're like, no, Danny, we really need to be going there as well, please do feed that in and then I'll build it into the timeline. But these are the groups, and obviously we're looking to come back to see this group as well once we've finished the community engagement ahead of going to final cabinet approval on the 18th of October for formal launch in January. So sorry if that was a bit of a whistle-stop tour, but just keen to get your feedback really on things that maybe we need to include or may have missed. So I shall hand back to you if that's okay, David.
Would you like just to clear the screen? That's great. And I have got, let me just, there we are, that's great.
Sorry. Yeah.
Elliot, do you want to kick us off while I just, there we are, I can see who's indicating. Elliot, if you'd like to kick off in response, thank you.
Yeah, thank you. Thank you all. Really, a really good presentation, and actually a really nice strategy. And I think the public-facing part of this, and the language and the clarity about how we communicate with families and children and professionals is brilliant on this. We've talked about we might steal some of it actually for some of our communications as well. I think it's really good. So. I think we're engaged with you in terms of the discussions about it, and from an HCT perspective, and the integration, how it integrates with the children's strategy within the ICS. That's all really important, because I think children's heads aren't quite as neat as we like to think they are in terms of the services that we have. And I think you've got in there about no wrong door for entering these services, but I think we need to push much harder in terms of clarifying how services fit together and how they work behind that once they get into a particular door, even if it's the wrong one. So I think we need to focus on the sort of gaps in the service that we've got, how we make those easier to navigate, and how we acknowledge that actually there are some parts of children's services where we currently have gaps. So I'd point to OT in CAMS, for example, and there are bits that are just missing in that jigsaw, or pieces of that jigsaw that are just missing. We need to find a way at least to work around those if we can't find a way of solving them. I think lastly, I'd say in terms of workforce, we need to be clear and acknowledge where we've got workforce shortages as well, and we're not going to be able to plug those in the short term. I think particularly speech and language therapy, where we are struggling, and we will struggle. How do we support professionals who access those services? I'm thinking particularly in the schools. How do we give them, given that it's a continuum of access into those children's services, and a continuum of need, probably I should say more accurately, how do we support people at the lower end of that need to work with those children in schools and support them to do that without them feeling overwhelmed, and then feeling that they can get access to the services at a higher level when they need them? So, Richard, I'd really support the direction in it. I think we need to push ourselves further and deeper, if you like, in terms of the integration behind that across a range of services. Yeah. And also be mindful of the workforce and challenges, and how we work around those in the short term, and try and solve them in the medium term.
Elliot, that's really helpful. You remind us of the complexity around working with children in this area, and my thanks to Jenny and Joe and to Danielle for highlighting that through the presentation and of course the report. And I think we need to embrace that complexity, and the way we do that is by integrating as far as we possibly can, so that we bring all of that talent together. And especially if we're going to be challenged on the recruitment and retention, we're going to need to do that even more. So I hope we are pushing at an open door, and the ICS gives us that opportunity, and we mustn't lose it. So I thank you all for that welcome in that direction. I've got a lot of people that wish to speak, so I'll shut up. So Sarah, then Teresa, then Jenny.
Thank you, Richard. Yes, just a very quick comment. Great to see that sort of like a whole systems approach is being taken here, and the interconnectedness with health and social care. I was just not clear, though, exactly where the VCSE is going to feature within the strategy. And I wondered whether there could be sort of a clearer signposting to how the sector is really important to support the whole families, not just the children and young people themselves, and whether that could be sort of more clearly stated.
Guys, I'll let you answer.
Jo, did you want to cover that one?
Yeah, sure. No, absolutely. Thank you very much, Sarah. And you're absolutely right to raise that. And it is very much part of our lens and it's very much part of our engagement strategy. What we can do is just surface that a little bit more explicitly, so that people across the system know that we're engaging at that level as well. But thank you for the comment.
Yeah, and I guess thinking about my previous role, linking across through into the wellbeing unit, where of course young people become adults and of all that community activity taking place, and linking through in that way. So that's helpful. Thank you, Sarah. Teresa.
Yes, thank you, Richard. I'd just like to say thank the team actually for pulling this together. They've been working really hard on the SEND portion of the portfolio, as it were. It's really important to us, can I say? And we do acknowledge that there are problem areas, because I suspect people listening to this particular webinar, in effect, will be saying, well, what about? We know that there are a lot of issues still, and especially around communication. So I acknowledge that, and that's something that we're working on. But I also say that it's really important that whilst we roll out this strategy, the consultation, that we make it really clear to residents and families that it's not just the county council, it's everybody, because a lot of the complaints that we get are actually health related, and it's about ensuring that parents understand that it's a whole system that needs to look after their child. So I think that's really important, and I know that we'll bring that out. But I really do welcome what people are saying today. Thank you.
Okay, thanks, Teresa. Jenny.
I think Jane was before me, actually, Richard, so I'm happy to go after Jane. Thanks.
Okay. Jane, and then Jenny.
Thank you, Jenny. I think probably three areas I wanted to bring out, or sort of test out of it, I guess, with this. So clearly, obviously, hugely welcomed, but I suppose just looking at where we should go further, faster, deeper, etc. I think in terms of broader engagement with health, if there isn't already a good link into the place-based partnership work, as well as formally through the ICS Children's Group, I think it would be important to have both, because through the partnership groups, the place-based partnerships, and particularly primary care networks, you'll get much more insight into at ground level what actually works, or where the hiccups are in a way that we possibly won't through a different lens. So that was just to sort of encourage that. I think the second element that I'd sort of pull out, and it relates in part to Elliot's point around workforce, I think it's really important that we don't make the perfect the enemy of the good when we're working through SEND. And if we pick up speech and language therapy just as an example, it's a professional group which we've struggled with, certainly since my now 23-year-old needed speech and language therapy 20 years ago. And that would tell me that it's not getting materially better. But what we can do, and we've seen actually through the COVID vaccination programme, is challenging ourselves to think differently and say, of the workforce available to us, how could we upskill people to provide different levels of care under supervision, as opposed to we have a purist and perfect concept that it's unfortunate we can't actually meet. So there you go. Lovely model. Shame that it doesn't work in practice, sort of thing. So I think there's that sort of element to bring through. And I think the third element I just want us to really be cognizant of in the further development of this is that we don't create or reinforce the legitimacy of handoffs between different professional groups, whether that's within health, across education, children's social care. We're so used to the fact that different tribes do different things that we sometimes lose sight of the fact that from a family and a patient point of view, that is just transactional and unhelpful. So I suppose my last element on that would be that we try and have the concept of for any child going through, or any family being supported through these strategies, the concept of at any time clarity about a lead professional, and that there is a navigator. There is someone who owns the responsibility overall, not just someone that says, I'm just doing the OT or I'm just doing the educational support. So I'll shut up at that point, Richard, but I think those are all pertinent points to the further development.
And they're also very practical, and I think you're hinting at us all needing to be a little bit more flexible, which means taking a little bit more of a risk. I think that's what you're hinting at with workforce development, and I'm sure I think ICS gives us that opportunity again, building into that potential for integration. Daniel, Joe, I'll leave you both to come in at the end. I think it's fine. And Jenny, then David Lloyd.
Thank you, Richard. I think that neatly brings me into two things. One, this is about inclusion. This is not always about specialism, and that is really, really important at every stage of a child's life, particularly in early years. And then the second thing, just to relay, as we talked about at the ICS board yesterday, that we are putting an expression of interest in for an integrated children's work, building on the work we've done around neurodiversity. And we brought that together really quickly because of the sound basis that we've got. But that is very much in line with an inclusive and integrated approach that we're developing in the county. Thank you.
That's great. Thanks, Jenny. David.
Thanks very much, Richard. And how sorry I am that it'll be the last time that I'll be following Jenny, because she always says such brilliant things. Although at least it'll mean that much of what she says, I'll not have to say, well, all of it's been said already, because Jenny's covered it off. So I suppose there's always an upside, isn't there? I suppose there are some difficult things to say here, although whilst congratulating and genuinely wishing to congratulate on this, and I think it's a great way forward. And specifically, at one level, SEND is of no consequence at one level to my formal role of Police and Crime Commissioner, other than clearly we all are looking at the most vulnerable that we have and in our society, and wanting to ensure that we better serve the most vulnerable in society. And there is probably, although I don't have the causal links, but there probably is a higher percentage of people with special educational needs and disabilities who are victims of crime, and I think that the victims of crime who are disabled are, I think, in many ways a much overlooked group, and we must do more about that. So you might say, well, everything is very important, but I'm not going to speak to that. I'm a little concerned that the number of those shown on page 67 of the report in SEND have increased from 24,500 in education to 27,500. Now, that is something which at one level perhaps shows that we are finding even more targeted approaches, which must be good, and our education must be targeted to individuals. That's brilliant. But at the end of the day, how can we afford, if we start with the budget, to provide the services which we are promising within this report for 13.5% and increasing of our student population? And that's going to be really quite difficult, I think, and it's a real challenge. I suppose it's not a challenge for my specific budget, although it is interesting that how many people have mental health issues who are involved in the criminal justice system, and that isn't the same as learning disability. Before someone says you misunderstand the two, I recognise that, but there are target areas that will cost all of our budgets more. But I think we do need to question in some ways, if we can't afford it, whether or not there is something which we need to reflect on even more. I might be wrong. It may be that there is the budget there, but I recognise when I had this portfolio, and I recognise when I had the resources portfolio, that it was very challenging to find the budget around children's services. And I didn't, of course, have the allied budget, which Terry rightly underlines, the health budget, which is just as important within it. But I think that we do need to reflect on that, and there is a danger. My time as a county councillor, I remember so much, seemed to be peppered with trying to support parents in getting statements for their children. This was the all or nothing moment. If they got a statement, they felt they were going to get the educational needs which were required. If they didn't, they felt they were not going to get anything. I recognise that this moves away from that already. We have moved away from that, and this is about a broader support for a broader range of young people, and I think that is super. But I still think we need to ask that question about is it really right that we've got a figure of increasing up to 15% who will be receiving special educational needs support? Or do we need to show that in a different way? Do we need to think actually that the level one would have probably felt would have been about 1 in 20 rather than 1 in 8? And I think we do need at least just to question that. However, I think it's a really good way forward. I think that I recognise that the working together, which I really support, and I always say whenever I speak, we must one day move to one budget, one plan, and this would be even better if we were talking about a cross-budget approach and it being a subsection of one plan for Hertfordshire.
Okay, thanks, David. If I bring it in, Joe, would you like to go first, and then Danielle?
Yes, please, Richard. Thank you. I just want to reflect and comment on a couple of points made by David. I think he makes some really good points. So thank you, David. And I think you raise a really important point around that increase in children, both with SEND support, which is the first figure that you cited, but also those with education healthcare plans. And Hertfordshire, along with every other, local authority or local area in the country, has seen that increase. It is in part related to the SEND reform back in 2014, which, as you're probably aware, brought just the legislative change, brought many more children into a system. It broadened the lens across an age range. But also within that, what we have seen are increasing complexity of need. And so that is also reflected within our system. We are not just focused on how we meet that need through specialist services. A big focus, and what we really need to drive hard at, is how we do that prevention and early intervention piece so that children are properly supported before they go on to need specialist support. And the way to do that is through collaboration and partnership work as a local area. So, for example, and referring back to the ICS, how do we work better to improve outcomes for children with SEND early on and in their early years through integrated pathways and multidisciplinary support? That's the piece we need to get right in order to better manage increasing demand and, you're right, increasing cost alongside that. I think the SEND review that we're waiting for, which I understand may be due anytime now in the summer, a key plank of that is going to be around a graduated response with a real focus on inclusion in mainstream provision, not just mainstream schools, but actually how within that do we better support really complex needs without children needing to go through a statutory assessment process and come out at the end with an education healthcare plan. There will always be some children, of course, who need to go through that statutory process, but making sure that we've got our early support piece right is going to be right at the forefront of what we do. Okay. And you're right, David, to highlight the fact that within our criminal justice system, we've not only got numbers of children who are victims with SEND, but also when we look at young people coming into the youth justice system, again and again, speech and language and social communication difficulties are disproportionately represented within that cohort. So we need to look across the whole journey of children and young people and think about integrated support.
Thank you very much. And the statistics for those who end up in prison, never mind youth justice, around those with SEND or mental health issues, often related to exploitation in the first place, is heartrending, and is something that as a nation we've really struggled to deal with. Danny, if you'd like to come in, would somebody just like to pick up Paul's point about the inequalities lens, which I think is hinting at the point about the various demands for SEND services. I just wonder if we could pick that up as well. Danielle.
Thanks, Richard. And this might actually help. So based on sort of what Joe was just saying before, and actually it might be helpful next time we come back to you is to share the action plan of what's happening behind the scenes, because there's a whole SEND strategy programme of activity that hopefully obviously gives a lot more meat to the bones about what we're actually delivering. So as well as linked to the graduated response, which obviously is making sure we've got the right provision, the right support for the right level of need. We're currently developing a banding model for all of our young people with SEND. We've already done that for mainstream schools. We're just building on the special provision and we'll move on to post-16 as well. And what that enables us to do is not only make sure that we give parity to our children across Hertfordshire, so it's not the voices that shout the loudest, but making sure there's the right provision for all and the right support at the right time. And of course, the funding that then goes with it. But also it means we can plan. So we've got a brand new special school place planning strategy, and that's helping us to prepare really and make sure we've got the right schools at the right place for the right type of need in time. So yes, this banding and modelling against the graduated response is absolutely integral, aligned to provision mapping to make sure we've got what we need in place at the right time. But of course, from the SEND strategy, because it's a public-facing document, you don't get all of that detail. So I think there is real benefit of us building that next layer down and bringing that back to you all so you can see. Alongside that is we've got a brand new health work stream that has now come into the SEND strategy programme. That's going to be headed up by Sally Orr. And that again will help with some of that join up around health projects and activity, again, to give that join up and parity across all of the system. But I just thought that might give you a bit more detail.
Thank you, Daniel and Joe. Thank you so much for that, for responding to the comments made. I think I'm delighted that we're in a position where we're not only reviewing the SEND strategy, not only is it looking to be more flexible and more inclusive, but actually integrated. It is definitely the direction of travel, and 300 additional places for in SEND schools is going to be welcomed by families up and down the county. So thank you all for planning those and getting those underway. This will undoubtedly come back to us, and I'm guessing in the autumn after further consultation. We would welcome that, and if you can take away some of the comments this morning and incorporate those, and I think those are useful. So we're not voting on anything this morning, but we are noting that and keep that good work going. It's fundamentally different, and for those parents out there who might be part of HCPA, or not HCPA, but the sorry, I've been too long in adults, but the Parent Carer Involvement Board. How's that? That's better. I'm there. Yeah. To you guys, I hope this is music to your ears, and if it's not, you can let me know. That's really good. Thank you. We'll move on to the agenda item 6, which is quite a quick update, I think, from Ed on the Better Care Fund. But guys, thank you. That's really the substantive there on SEND was really helpful. Contributions welcomed. Thank you. Ed.
Thank you, Chairman. Conscious that we have some newer members of the board as well. So just as a bit of background, the Better Care Fund is a programme and a source of shared funding in the order of approximately 80 million that underpins integrated activity across health and social care. And those of you who have been on the board for a number of years will know that in the typical course of events, this board receives regular reports on both the performance and impact of the Better Care Fund prior to onward submission to government. Those reporting arrangements were suspended during the pandemic, and we're still waiting for information as to kind of government's clear intentions for the Better Care Fund, and then what this board in turn will be required to consider and agree going forward. We do know there will be a Better Care Fund going forward. It's explicitly referenced within February's integration white paper, which also recognised that we're going to need to find a new way of allocating it in a world of a single integrated care system and CCG. At present, it's allocated by each CCG in the patch. I'm sure you'll all be glad to know that even without central government guidance, we have carried on doing things though and progressing activity. And this paper reflects on the extent to which integration activity supported by BCF has supported our system and our system's response to the pandemic. So, I mean, some prime examples for me would be all the integration that's supported across our acute trusts, our community health trusts and social care. That meant we were in a good position to respond to the discharge arrangements that came in place early in the pandemic. Or in another part of the system, the work that we've done to line up community navigators and NHS link workers in our GP surgeries and PCNs, which has allowed us to kind of complement those phenomenal efforts of the voluntary community, faith and social enterprise sectors, throughout this period as well. I think from an integration perspective, I think we should also recognise, the extent to which the pandemic has accelerated integrated activity that we'll want the Better Care Fund to maintain and build upon over the course of the next couple of years. So again, just as notable examples, the coordination of better community health and social care support for all of our care home settings, or somewhat more prosaically, but makes the accountants happy, the single conversation about bed purchasing and bed commissioning. So, one or a system coming together to make sure we're buying things effectively and efficiently. And so all those activities that the pandemic's really hastened on that we've got to capture and build upon going forward. So looking ahead for this financial year, while we wait for government guidance, I think we need to ensure that the Better Care Fund acts as both a platform for integrated system recovery, but also what it has done in the past, which is be a bit of an incubator for things we might want to try out in terms of integrated care. So section 5 of the report, and specifically section 5.3, details our understanding of what the government's key priorities will be for this fund, including a focus on self-management for individuals and effective multidisciplinary working. If I'm honest, the priorities in 5.3 aren't much different from what they have been. They're reworded, but they should all be areas that we're working on already. Section 5 also outlines other areas that I think we need to focus on in our BCF, including alignment with the NHS's Ageing Well programme and investment. All the work that happened pre-pandemic and is now even more important post-pandemic, or sorry, at this stage of the pandemic, around frailty and how we support the people in the community, specifically also frailty for people with physical disability and learning disability. And as mentioned already, just making sure that where the BCF is helping to support the work that I know is already underway, and I believe was discussed at the ICS Partnership Board this week, around how our voluntary community, faith and social enterprise sector have got both the platform and the infrastructure to lead and where necessary disrupt our existing ways of working. Two last points from me, I suppose, along with system changes, I do think we probably want the Better Care Fund to also act as both demonstrator and catalyst for those conversations we need to have about better integrated commissioning across the NHS, local government and wider partners within the integrated care system. Because while the Better Care Fund itself is focused on adult services, how we commission and plan together will need to work across children's public health. And to be honest, all those areas where our ambitions and intentions overlap. This is how we make sure that we're delivering against the ambitions of this board and the ICS more widely. So that is it in a nutshell, Chairman. The board is recommended to just note the emerging national picture, which is still unclear, but more importantly, I suppose, our own local intentions and how the Better Care Fund can support integration going forward. But rest assured, regular reporting as per old will resume in due course. That's me done, Richard.
Thank you, Ed. That's really comprehensive. It's whistle stop, but it gets the salient points out there. And I guess for me, the most salient point is that it's almost, this is the integrated working that we've been doing for the last, best part of 10 years now. and we'd really like to do an awful lot more, because what COVID has told us is that by working together we get better results, and we can get to better outcomes by working close together. And the discharge from hospitals was a classic example of that. And if we're going to overcome the backlog, working closer together, and discharge and recuperation and back into systems in the community is just going to be writ large to how we work. And so this is it brings the BCF, in a sense, it brings a sharper focus on it, and a brighter light, I think, shines on it. So let's take the success of BCF and see if we can work it into other areas, just as you suggested, Ed. That's really good. I've actually, it's obviously so good, Ed, that not a single person wishes to speak to it. So I think what we will do,
I'm used to that.
just in case anybody is coming in late and they're not. So I will just say that we will do exactly what you suggested, that we note this report, we see what the government's intentions are, and of course we've got the white paper coming through as well in the next few months. We've also got which will determine our ICS structures, for example, and I know there's very important conversations going on literally as we speak, particularly around geographies, but much more importantly about how we're going to work together, and hinting at those partnerships. Let's just make sure that we get the commissioning and the integration and the working together nice and strong, and just as strong as the community and partnership and well-being is at the moment. We need to feed that all into that. Needs to be stronger. I guess almost coming back to Jane's point about faster, deeper, further. It feels like that's the direction of travel, so let's do more of it. Thank you very much. So Ed, we'll note the report. Yours is the last item. Colleagues, that's not bad. That's 25 to 12. That's an hour and a half. You've got 25 minutes back. You can get a lot of emails done in 25 minutes. Thank you so much, everybody, for your participation this morning. And perhaps one last time, Jenny, on your retirement from HCC and wider Hertfordshire, our greatest respect and our best wishes to you and your family.
Thank you very much, Richard. Thanks, everyone.
Okay, take care.
Thank you.
Bye-bye now. Bye-bye.
All the best, Jenny.
Bye.
I'm sure we'll have a chance to share cake at some point.